Welcome everyone for the class on endocrinology. The first topic what we'll be seeing and the important topic is diabetic ketoacidosis. It is simply known as DKA. The simplified version of the pathophysiology what I'll be taking, it is not in depth, it is very much simplified and it is a concise version. What are the precipitating factors for a DKA? It can be infection, infarction like myocardial infarction, or it can be a stroke, or it can be a mesenteric infarction. So infarction in any part of your body, any intercurrent illnesses, especially severe illnesses like sepsis, insufficient insulin they have taken. So you can remember with I, there are four I's. One is infection, infarction, intercurrent illnesses, and insufficient insulin. Whenever there is a precipitating factor, what will happen? There will be increase in counter-regulatory hormones and decrease in the insulin. This will result in breakdown of the fatty acids, resulting in formation of ketones. This is the basic pathophysiology of diabetic ketoacidosis. Whenever there is presence of ketones are nothing but acid. Because of presence of an acid, the pH will go on the lower side. So it becomes more acidotic. So the pH will be less than 7.3 and bicarb will be less than 15. If one of these parameters is there, that is enough. So this is one criteria. The next one is the blood glucose levels should be more than 11 millimoles per liter. Remember that we always in UK use millimoles per liter, not milligrams per deciliter. If it's a known case of diabetes mellitus also is fine. If it's a known case of diabetes mellitus and the glucose levels are 10 or 10.8, that should be sufficient to satisfy. It's not necessary that always the glucose level should be on the higher side in DKA. And ketone should be on the higher side. In blood, the ketone should be at least more than 3 millimoles per liter. In urine, the ketone should be at least more than 2 plus. That means 3, 4, 5. So it has to satisfy all these three parameters to call it as a diabetic ketoacidosis in an adult. We're just talking about an adult. So in an adult, this criteria needs to be satisfied. All three criteria needs to be satisfied to call it as a diabetic ketoacidosis. What are the clinical features? Clinical features depends on what you're seeing. For example, in because of high sugar levels, they will have an polyuria and polydipsia. So they'll be drinking a lot of water and urinating a lot. Urinating a lot will result in a dehydration. Dehydration will cause tachycardia and hypotension. Gastrointestinal symptoms are the main presenting symptoms. Usually the patient who has an DKA presents with an abdominal pain, nausea, and vomiting. Why do the patient have an GI symptoms? This is because of impaired gastric motility. The autonomic system gets involved, resulting in impaired gastric mobility that results in abdominal pain, nausea, and vomiting. Respiratory symptoms. Respiratory symptoms are mainly due to the compensation of metabolic acidosis. Metabolic acidosis is seen because of the production of the ketones. So to compensate the metabolic acidosis, you start breathing fast. This breathing is known as Kussmaul's breathing, and it smells, the breath kind of smells sweet because of presence of acetone. Neurological symptoms, because glucose is the main substrate for the energy for your brain. Other than that, there is no other substrate which can utilize the brain. So brain cannot utilize other than glucose, anything else for the energy. For that particular reason, they end up having neurological symptoms like altered sensorium, confusion, sometimes even the patient can go into coma. Investigation wise, you need ketones for the diagnosis, you need pH. So you're getting a venous blood gas because we're not concentrating on PaO2 or PaCO2 values. We just need the pH here and bicarb, which you can easily get it if you get a venous sample also. So venous sample is preferred over an arterial sample, mainly because if you're collecting an arterial sample, it is a painful procedure. For that particular reason, you're not getting an arterial sample. You're just depending on the venous sample. Blood sugar levels, again, for the diagnosis, we need all these three. Electrolyte abnormalities, especially the potassium levels, that's why we need electrolytes. To know the underlying cause, is it an infection? That's why we need a full blood count, urine analysis, cultures, chest x-ray, depending on the presentation, for basically looking for if there is any source of infection. ECG tropi, we are looking for infarction. If there is a stroke, for example, you're thinking of this patient might be having a stroke. At that point of time, you might even have to go ahead and get a CT brain done. So depending on the presentation, underlying cause, you need to guess it out and get relevant investigations done. What are the complications? Complications are mainly because of the treatment rather than DKA itself. Okay, DKA, what will happen because of a diabetic ketoacidosis? Most of the time, it is the severe dehydration what the patient will be presenting with. Along with it, when you start the treatment, the patient can go in hypokalemia. Okay, hypoglycemia, if you start giving large amount of insulin, if you rapidly correct the defects what are present because of the diabetic ketoacidosis, cerebral edema can develop, including in pulmonary edema. If the patient GCS is on the lower side and if he starts having orally, can result in aspirational pneumonia. So he can aspirate the food particles resulting in an pneumonia. This much basically we are look out for what is the definition for an adult diabetic ketoacidosis and what is the diagnostic criteria, what is the presentation, what are the investigation needs to be getting. Now we are entering into the pediatric diabetic ketoacidosis. In pediatric diabetic ketoacidosis, the definition for the diagnosis of DKA differs. This slight changes are present. Acidosis should be there. Similar, the pH should be less than 7.3 or the bicarb should be less than 15, similar to that of the adults. Ketones, significant amount of ketones should be present in the blood, that is more than 3 millimoles per liter. Again, similar to that of the adults. If these two criteria are satisfied, that is sufficient. Doesn't mean that this patient should be a known case of diabetes or the glucose level should be more than 11 millimoles per liter. That third part, what we discussed for an adult, doesn't exist for the pediatric age group. One more thing you need to understand is in the pediatric age group, DKA is classified as mild, moderate, and severe DKA, depending on the pH. If the pH is between 7.2 and 7.29, then it is known as mild. If it is between 7.1 and 7.19, then it is moderate. If it is less than 7.1, then it is severe. Main thing what you need to remember is less than 7.1, it is severe because it is helpful for the management. That's why you need to remember that the pH less than 7.1, it is a severe DKA, what you need to remember. Investigation wise, it is very much similar to that of the adult DKA. There is not much changes at all. Blood glucose is required. Electrolyte abnormalities, especially the potassium, you need to get it done. Blood gases, here blood gases, venous, if it is an teenager or someone who is 4, 5, 6 years. If it is a very young child, you are having around 1 year, then you need to get an capillary blood gas, then venous might be difficult to get it done. Ketones, blood ketones, we are preferred. That's why in pediatric age group, I'm just mentioning blood ketones. I'm nowhere mentioning the urine ketones. Blood ketones are much more sensitive, much more better parameter compared to the urine ketones. So blood ketones, you are getting it done. When you're getting it done in blood ketones, what you're measuring is beta hydroxybutyrate. You're not measuring other ketones. You're just measuring beta hydroxybutyrate. If you're suspecting an infection, for example, the patient is having cough and fever, you're suspecting a pneumonia, you need to get a chest X-ray done. If you're suspecting an meningitis, then get a CSF done. Your sore throat, throat swabs might be required. Sepsis, blood culture, urinary tract infections, urine analysis and culture might be required. So depending on the presentation, different investigations, you will be getting it done to know the underlying cause. Management. Management is a bit complicated. It differs from adult to pediatric. It is important. So first, what we'll be discussing is the adult one, followed by the pediatric one. I have put it side by side so that you can compare and you did not get confused during the exam or during revision for that per se. You get a patient with a diabetic ketoacidosis. You're diagnosed with the criteria what has been given. First, you will be seeing whether the patient is in shock. Shock for us, systolic blood pressure being less than 90. If the patient systolic blood pressure being less than 90, you will resuscitate with IV fluids. Similar to any other medical cases or the trauma cases resuscitation, we resuscitate with an crystalloid fluid that is normal saline. Normal saline is the preferred fluid in diabetic ketoacidosis. We give in the range of small boluses like 500 ml to 1000 ml of normal saline over 10 to 15 minutes and see how's the response. Once shock is dealt with or the patient presented he doesn't have the shock, then how do we do in fluid resuscitation? Fluids are given in this manner. First hour you give 1 liter. In next 2 hours you give another liter. In next 2 hours you give another liter. So you can follow this. So up to 5 hours you are giving. Usually the patient doesn't stay in the emergency department more than 4 hours. So in 5 hours you can dispatch them and the further management is more for the acute medicine. Insulin infusion. Insulin infusion is started at zero point 0.1 unit per kg per hour. Someone who is 70 kgs, for example, it is 7 units what you are starting per hour infusion you are starting. The insulin which is used, usually it is a short-acting insulin. Human actrapid is the preferred one. Human actrapid what you will be using it. When do we increase the insulin infusion? We kind of continuously monitor the ketones, the glucose levels, all these parameters will be monitoring. Mainly, we'll be monitoring the ketones. Ketones, if they are not falling by 0.5 millimoles per liter per hour, then we end up increasing by 1 unit per hour. Potassium values are very important. Usually you need to have an potassium value before you start an insulin infusion. That is what the advice is. So once you have the potassium values, then you look at the potassium values what you're having. If it is more than the normal range, that is more than 5.5, nothing needs to be done. If it is in the normal range, that is between 3.5 to 5.5, that is the normal range, then you add up 40 millimoles per liter. Sorry, then you add up 40 millimoles per liter to the fluid what you have been giving. For this fluid itself, you just add 40 millimoles per liter. That's it. For example, 1 liter of normal saline you started over an hour's time, you just add 40 millimoles per liter in that fluid. If it is less than 3.5, then you will be adding around 60 to 80 millimoles per liter for the same fluid what you have started. You're not starting any separate infusion. Your glucose level starts falling rapidly and they have come down to 14 millimoles per liter. At that point of time, what you'll be doing? At that point of time, the recommendation is you start on 10% dextrose at 125 ml per hour. You need to continuously monitor. For example, here ketones values are required every hourly. That's why ketones needs to be got it every hourly. This needs to be checked every hourly, because if it falls less than 40 millimoles per liter, then you need to start 10% dextrose at 125 ml per hour. That's why monitor this every hourly. pH and bicarbonates first every hourly, then every 2 hourly you'll be monitoring. Electrolytes every 4 hourly if you monitor, that should be sufficient. This is the management for the adults. What about the pediatric age group? In pediatric age group, it changes. Okay, someone has a shock definition changes, that means less than fifth percentile for that particular age. So you need to use the formula and you need to find out what is the blood pressure which is less than fifth percentile for that particular kid and see whether the kid is in shock or not. If the kid is in shock, you resuscitate by giving 10 ml per kg every 15 minutes till the blood pressure has improved. At the presentation itself, the patient is not in shock. Then what you do? Then we give something known as slow bolus. What is slow bolus? Slow bolus is 10 ml per kg is given over 30 minutes instead of giving over 15 minutes. This is known as slow bolus. So any patient, pediatric patient who presents to the emergency department in DKA and not in shock, all of them get an slow bolus. Then you calculate the fluid. Calculation of the fluid, I'll be explaining here now. So what is the requirement? Requirement is deficit minus the 10 ml per kg bolus given in non-shock patient. That is the slow bolus what you are given. Only that you are minusing. If you given this bolus in a shock patient at over 15 minutes, then that one you are not subtracting. This one you are subtracting only if you are given in a non-shock patient, plus the maintenance. First, let us calculate the deficit. Deficit is fluid deficit into the kgs, that is the body weight, into 10. For example, we'll take his 10 kgs. How to know the fluid deficit? Look at the pH. pH is less than 7.1, suggestive of a severe decay. Then you take it as 10. If the pH is 7.1 or more than 7.1, then you take it as 5 as the fluid deficit. We will consider here is a severe deficit. So you'll multiply by 10 and into 10. So how much it will be? It will be 1000 ml. And this 1000 ml to be given over 48 hours. Remember that. And from this 1000 ml, you are subtracting, for example, if you're given around slow bolus of is a 10 kg, so 10 into 10, you are given 100. So you'll be subtracting 100 here. So it will be 900 ml what you'll be giving. Okay, this 900 ml is this much for how much you have calculated, but we have not calculated the maintenance. Maintenance depends on the kgs. First 10 kgs is 100 ml per kg. This is 10, we have taken 1000 ml. So what we are doing, this over 24 hours, it becomes 450 plus 900. This much should be given in first 24 hours. That's how it is calculated. There is an example also I put up here so that you get a better understanding. There's one more example. We'll go through this example now. So we have in 20 kgs, 6 years old boy whose pH is 7.15. 7.15, that means more than 7.1 or 7.1 or more than 7.1 it is. So you consider deficit as 5. He has received an bolus 10 ml per kg bolus of 200 ml fluid over 30 minutes. 30 minutes, it's a slow bolus what you are given. So 200 ml of slow bolus what he has got it. As part of the initial resuscitation, his ongoing fluid will compromise. So how do we calculate? Now, first let us calculate the deficit. Deficit is 5 into kgs. The kgs they have given, the weight they have given, that is 20 into 10. How much it will come up? That is the 1000 ml what it will be coming up. If you multiply it, 5 into 20 into 10, it will be 1000 ml. Then from this, we need to subtract the 200 ml rapid bolus what you are given. It will come to, sorry, 800 ml. This 800 ml needs to be given over 48 hours. So 800 divided by 48, approximately it will come to 17 ml per hour. What is the maintenance? Maintenance is his 20 kgs. So first 10 kgs into 100 you are doing it, it becomes 1000 ml. Next 10 kgs you're multiplying by 50, it becomes 500 ml. You add up everything, it comes as 1500 ml. Divide by 24, it comes as 62 ml per hour. So you are adding the 17 ml what you have got here, and you are adding the 62 ml what you have got here. So total infusion what you are giving is 79 ml per hour. So it is a bit complicated, but this has to be done to manage and pediatric DKA patient. It is very helpful. You cannot just push the fluids in a pediatric age group, because we are very much worried about a complication that is in cerebral edema, which is very commonly seen if the fluids are not appropriately calculated and given. If some little bit more of fluid you give it, you might end up having a cerebral edema, which is kind of life-threatening. Now let us go back to the management again here. So that is the part of the fluid management. What about the insulin infusion? Insulin infusion is started only at 0.05 units per kg per hour over 1 to 2 hours. Okay. After 1 to 2 hours of IV fluids. That means you are not immediately starting the insulin infusion. You're waiting at least for an hour's time. After you are given at least 1 hour of IV fluids, then only you are starting the insulin infusion at the half of the rate of the adult. In a severe DKA, that means the pH is less than 7.1, or in an adolescent, anyone around 12 or who looks like an adult also you can consider as an adolescent. For them, we started at an adult dose, that is 0.1 unit per kg per hour what you'll be starting. Again, do not start immediately, at least give hours of fluid, then you start. What about the potassium? Potassium, if it is above the normal range, you are adding 40 millimoles per liter to the fluids what you are giving here, what you are calculated to the same fluids you are adding it up. But this addition shouldn't be added up immediately. You need to wait till the patient has passed the urine. Once the patient has passed the urine, then you can add up 40 millimoles per liter. If it is in the normal range, what you'll be doing? In a normal range, just add 40 millimoles per liter added to the fluids itself. Nothing needs to be done. If it is less than normal range, that is less than 3, it is 40 millimoles per liter to be added, plus insulin shouldn't be started till the potassium values goes more than 3 millimoles per liter. So hold on, recheck the potassium levels. Once the potassium levels are more than 3 millimoles per liter, then only you are starting the insulin infusion. Otherwise, do not start the insulin infusion. What if the glucose levels falls less than 14 millimoles per liter? At that point of time, change the fluid to 5% glucose. Okay, entire fluid you are changing, you're not starting another infusion. In adults, we usually start another infusion. Here, we do not start another infusion. The entire fluid, the entire normal saline is changed to 5% glucose. Do we change an insulin infusion rate? We usually do not change it unless and until you are started at 0.1 unit per kg per hour because it was a severe decay. Then you can change it to 0.05 units per kg per hour. Ketones and capillary glucose should be checked every hourly. Urea, electrolytes, bicarbs, pH, laboratory glucose levels should be checked every 2 hourly. Then you need to check every 4 hourly. So initially, after 2 hours, you'll be checking. After that, every 4 hourly, you need to be checking. What about if the patient is on insulin pump? If the patient is on insulin pump, stop it. Okay, usually it will be subcutaneous implanted insulin pump will be present. How to stop? The patient will be aware of it. It depends from the manufacturer to manufacturer. If you ask the patient to stop it, they usually stop it. Or the contact details would have been given on the device itself. You need to call, if you're not aware of the device, you need to contact them and make sure you have switched it off. If you do not switch off the insulin infusion, recurrent hypoglycemic attacks can happen because the amount of insulin what you are giving is more than what is required for the patient. If the patient is on long-acting insulin, continue giving the long-acting insulin. Complications. The important complications I keep on saying, especially in the pediatric age group, is the cerebral edema. Especially in the pediatric age group, while you are treating and decay, suddenly the kid becomes irritable and start complaining of a headache, has an vomiting. Signs and features suggest you of an high ICP. slowing of the heart is seen, a Cushing's reflex is seen, then you need to immediately think it might be a cerebral edema. Immediately, the IV fluid what you are giving is cut down by 50%. For example, IV fluid infusion is 90 ml per hour, cut down by 50%. So 45 ml per hour you will be continuing. Along with it, you need to give hypertonic saline or mannitol needs to be given. So this is the main management for the cerebral edema. If at all, if it develops, you need to closely observe for cerebral edema, especially in pediatric age group. It is one of the most common complications which can happen, especially if you're giving the fluids which are not been accurately calculated, end up giving more fluids, can develop in cerebral edema. What is euglycemic decay? As the name suggests, euglycemic, the BM, the sugar levels will be in the normal range. Why does the patient has sugar levels in the normal range? Usually we expect the sugar levels to be on the higher side. This is the basic pathophysiology of a DKA. What happens? What happens? Because of increased education about the complication of the hyperglycemia, that is DKA, these patients end up treating themselves by giving subcutaneous insulin. So inadequate amount of subcutaneous insulin they are treating by themselves. The mainstay of the DKA treatment is giving IV fluids, but they check at the home the sugar levels on the higher side. They keep giving themselves the subcutaneous insulin. This subcutaneous insulin will bring down the sugars to the normal range, but the ketones will still remain on the higher side. That's why it is known as euglycemic DKA, a partially treated DKA where the patient is still dehydrated, where the patient's ketones levels are still high, only the glucose levels have fallen down because the patient has taken supplementary insulin. What you do in the management of the management of this euglycemic DKA, it is very much similar to DKA itself. There are nothing changes are there. Because this patient's glucose levels are usually less than 14 millimoles per liter, you directly or immediately start this patient on 10% dextrose at 125 ml per hour. Directly at the initial stage itself, you'll start it off because the glucose levels are in the normal range. Then you start on the insulin infusion, 0.1 units per kg per hour. Same thing. In spite of you starting on 10% glucose, still the sugar levels are going on the lower side and they are falling down rapidly. Then you need to reduce the insulin infusion to 0.05 units per kg. When it is very commonly seen euglycemic, if they want to test you in the exam, usually in the stem of the question, they will be giving you one of this, that is sodium glucose co-transporters. These are the oral hypoglycemic drugs or oral anti-diabetic medications, what usually are very commonly used nowadays. This ends by glyphoxin, 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 glyphoxin. Just remember, if a name is given which ends with a glyphoxin, it is a sodium glucose co-transporters. They are prone to cause an euglycemic TKA. So in the stem of the question, they will mention one of the glyphoxin. Along with it, they will mention that the glucose levels in the normal range, but the other parameters will be dearranged. What are the other parameters? The pH usually will be less than 7.3. The ketones will be significantly elevated, satisfying the decay definition, but the glucose levels is in the normal range. That's when we call it as an euglycemic decay. They will be giving one of these drugs will be present. What is hyperosmolar hyperglycemic state? As the name suggests, hyperosmolar. That means the osmolality will be on the higher side. Hyperglycemic, significantly very high glucose levels will be present, but there will no significant amount of ketones will be present. Because there is absence of significant amount of ketones, the bicarb usually will be more than 15. The pH will be more than 7.3. There will be marked amount of glucose will be present. Glucose in the range of more than 30 millimoles per liter. And the osmolality will be significantly high. How do we calculate an osmolality? Osmolality is calculated with this formula, that is 2 times the sodium plus potassium plus urea and plus glucose. Usually it is in this normal range, that is 275 to 295. If it goes, it should go more than 320 to call it as an HHS, which stands for hyperosmolar hyperglycemic state. So remember, 5 points should be there. These 3 points are easy to remember because it is something opposite to that of the DKA. In DKA, you say the pH should be less than 7.3, bicarb should be less than 14, and there should be significant amount of ketones. So you are telling this is not a DKA by putting this in the definition. So these are all included in the definition. Along with it, the osmolality should be on the higher side. Along with it, the glucose level should be significantly. How significant? Usually it will be more than 30 millimoles per liter. So marked hyperglycemia. Because of this significant amount of high glucose levels, these patients will have osmotic diuresis. They will urinate significantly more than any normal person. Because of significant of increase in urine output, these patients will have significant dehydration. Severely dehydrated, these patients will be. So the mainstay of this treatment for these patients will be giving fluids. Large amounts of fluids you will be giving for these patients. So fluids, how do we give the fluids? Very much similar to the DKA. So what is mentioned in the DKA is the same thing what you can follow here also. So what was mentioned, if the patient was in shock, you will resuscitate with what? 500 ml to 1 liter of normal saline fluid. Here also the same thing. If the patient is in not shock or the shock is improved, no shock is present, then similar to DKA, you will be giving 1 liter over 1 hour initially. Next 1 liter will be given over 2 hours. Next 1 liter will be given over 2 hours. So similar manner to the DKA, the management will be continued. Even the electrolytes are managed in the similar manner how an adult DKA is managed. Monitoring voice. Monitoring voice, you're monitoring two main parameters. One is osmolality, another one is glucose. Okay, you want the osmolality and glucose to fall at a rate of 5 millimoles per liter per hour. If it is not falling at this rate, that's when it is a little bit of alarming for us and see what is wrong with this. We are just giving fluids, whether fluids is sufficient or not. That's when we start thinking about it. Okay. When to start an insulin in this patient? Insulin is not a mainstay of treatment for an HHS. We only start an insulin at a very low dose, that is 0.05 units per kg per hour. That is almost the 50% of the adult dose what we are giving here. When beta hydroxybutyrates is more than 1 millimole per liter. Okay, ketones are insignificant. Yes, it is not more than 3 millimoles. But if it is more than 1 millimole and less than 3 millimoles in this range, if you are having it, then you go ahead and start the insulin. If the glucose, what you are monitoring here, is not falling down by 5 millimoles per liter per hour, then also you go ahead and start on low dose insulin. These patients are severely dehydrated, so risk of having a thromboembolism is very high. So you need to give them prophylactic low molecular weight heparin. This is primarily happens in an type 2 diabetes, unlikely to happen in a type 1 diabetes. Very commonly seen in type 2, unlikely in type 1. That's why I keep saying adult, and compare with an adult TKA. Hypoglycemia. The most commonest cause for hypoglycemia is a mismatch between an oral hypoglycemic drugs or the insulin what they are taking with the calories what have been spent. What do I mean by this? Basically, what I mean is they have taken insulin or they have taken an oral hypoglycemic drugs and they have forgotten to take their meal. So they have forgotten to eat the food. Usually the recommendations are given is you take the insulin and take your meal. They have taken the insulin, forgotten to take the meal, resulting in an hypoglycemia. That is the most commonest cause for hypoglycemia. What are the other not so common causes, which can be remembered with a mnemonic known as explain, where EX stands for exogenous drugs. Okay, exogenous, like you consume a lot of alcohol, can go into hypoglycemia. Beta blocker overdose, like propranolol overdose or bisoprolol overdose, can cause hypoglycemia. Pituitary insufficiency, liver failure is one of the important causes, as we discussed in the last class itself, where I said that acute liver failure or chronic liver failure can predispose to hypoglycemia because gluconeogenesis happens in liver. Addison's disease is one of the criteria where you look out for the glucose values. Islet cells of tumors like insulinoma, very rarely it is seen. Non-pancreatic insulin secreting tumors, again, very rare cause. Okay, these are the main causes. Most common cause is the first one. So how do they present? They usually present with autonomic system symptoms. These symptoms are seen when the glucose levels are between 4 to 2.5. That is 4 millimoles to 2.5 millimoles. Anyone who is having less than 4 millimoles, we consider them as an hypoglycemic. Between 4 to 4 millimoles, we see an autonomic system symptoms. Like this patient might be having some amount of dizziness, blurring of the vision, sweating, tiredness. They feel quite hungry and they feel a little bit nervous. There is some amount of headache is there, some shaking, some palpitation. These are all autonomic symptoms. When do the actual neurological symptoms develop? What are the neurological symptoms? There is change in the GCS. There are focal neurological deficit, seizures. These neurological symptoms are only developed if the glucose values are less than 2.5. Sometimes less than 3 also can develop in an elderly person. In a young person, less than 2.5. Okay, less than 4 itself, they'll not throw up and seizure. Significantly low hypoglycemia should be there for to throw up and seizure. Investigation wise, glucose obviously required, potassium values and ECG is required, liver function test because liver failure is one of the causes for urine creatinine. You need to get it done as in routine for this patient. Management is important. How do we manage? Depends on the GCS. Is the GCS normal or the GCS is low? If the GCS is normal, then you are treating them orally. Orally, first we give fast acting carbohydrates. Okay, like in chocolate, you can give it. In most of the emergency department in NHS, glucogel is available. This is the glucogel it is known as. So it is in paste, you place it sublingually and it gets absorbed very fast. After that, you ask them to have a meal, basically have a sandwich or have a few biscuits. They are long-acting carbohydrates to prevent recurrence of hypoglycemia. If the GCS is low, what we do if the GCS is low? If the GCS is low, intravenous glucose is the preferred one. Okay, 10% glucose should be given 50 ml boluses, then recheck. You keep on repeating the 50 ml boluses and keep on rechecking it. What about giving more concentrated like 25% and 50% glucose? This is not recommended to be given over on peripheral line. This causes irritation to the veins and can result in thrombophlebitis. For that particular reason, to prevent thrombophlebitis, we give an less concentrated glucose, that is 10% glucose, what is given small boluses, that is 50 ml, you give it recheck, 50 ml, you give it recheck, and you keep repeating till it comes to a normal range. Glucagon 1 mg IM. When you're not supposed to give it, you're not supposed to give it when the patient is on sulfonylureas drugs or liver failure is present. It is ineffective in these conditions. When can you give it? When you're not able to secure an IV line, because this is given intravenously. When you cannot secure it, the patient is having active seizures, difficult to secure an IV line. The patient is quite aggressive and agitated. Then you want to give it IM. Then glucagon 1 mg IM is the preferred method and preferred drug. Anyone who is taking sulfonylureas drug or in long-acting insulin needs to be admitted. Okay, or anyone where you cannot find the cause for the hypoglycemia, you need to admit. Why we need to admit when the patient is on sulfonylureas drugs or long-acting insulin? Because recurrence of hypoglycemia is seen. Why recurrence of hypoglycemia is seen in these patients? Because it is a long acting, it acts for approximately for 24 hours. This sulfonylureas drugs also act for approximately for 24 hours. For this particular reason, they can have recurrent episodes of hypoglycemia. So we admit them and start them on 10% dextrose at 100 ml per hour. So this is the infusion rate what we'll start them on. Next thing is, if someone who is on sulfonylurea drugs and has some kidney injury, like and chronic kidney disease, these patients are very much prone for recurrent hypoglycemia in spite of starting them on 10% dextrose infusion at 100 ml per hour. At that point of time, octreotide will be very helpful. In spite of giving any amount of sugars at any rate, these patients will, after few hours, again, they'll have an hypoglycemic episode. To prevent that, octreotide is a very helpful drug. Okay. Every 15 minutes, you need to recheck. Okay. You give a bolus, you recheck. You give a bolus, recheck. Remember that you are not rechecking in the same limb. You need to check another, or you need to use another limb to check it. Hypoglycemia in pediatrics. What are the changes in hypoglycemia in pediatrics? When you get an capillary blood glucose levels done, which you do it in the bedside, that is an capillary blood glucose done. They are not very accurate in the pediatric age group. You need to get an lab values done. Okay. You treat the patient if it is less than 2.6 millimoles per liter, because they tolerate very well the hypoglycemia, and treatment usually will not be required. Your treatment is mainly required if it is less than 2.6 millimoles per liter or the patient is symptomatic. Otherwise, usually we do not treat them. But from practical point of view, though these are the guidelines, from practical point of view, anyone has a low glucose levels and asymptomatic also, we give them some food to eat so that the sugar levels comes high. Okay, that's the basic thing what you need to remember. You check the glucose levels every 10 minutes here compared to that of the adults every 15 minutes. Again, you see the GCS here. If it is GCS is in the normal range and it is an infant, you usually prefer giving milk feeds. If this is not mentioned in the options, then choose glucogel. That is more than 1 hour's fast-acting carbohydrates like glucogel you'll be giving, followed by and long-acting carbohydrates like in biscuit or in sandwich can be given. What about low GCS? Low GCS, it is preferred to give an glucagon here instead of giving an intravenous glucose, because most of the time getting an IV cannula will be difficult in a pediatric age group. These are the dosings which you may not need not remember for the exam. But someone more than 25 kgs is an adult dose. Less than 25 kgs is half of the adult dose, easy to remember. Intravenous glucose, what we are giving is 10% glucose, what we are giving to a max of 5 ml per kg, we can give it. That means initially we start at 10 ml per, 2 ml per kg. If you want, you can increase and give as much as 5 ml per kg also can be given. New diagnosis of diabetic mellitus, that is DM. Someone who has diabetic symptoms like polyuria, polydipsia is present, along with significant weight loss is there. Those are the symptoms of diabetes. And you do and random sugar levels which are more than 11 millimoles per liter, you can label them as an diabetic mellitus. Or someone who has an HbA1c more than 6.4%, also you can label them as an diabetes mellitus. This is about the glucose levels. So what we are learned? We are learned about DKA, we are learned about the HSS. Definitions are very important here. The treatments are very important here. The complications are very important. So everything what we are taught is important. Nothing you can skip it. Then we are already also learned about low glucose levels, hypoglycemia, both how to treat in a pediatric age group as well as in an adult age group. All the topics are important. I'll just go through the questions here before I enter into the next topic. When we will start the insulin infusion, after 1 liter of normal saline or immediately? You do not start immediately insulin infusions in the pediatric age group. I'm assuming that you're asking in the pediatric age group. You do not immediately start in the pediatric age group. You need to wait to do it started. So at least 1 to 2 hours you will be waiting to start insulin. In that, depending on the calculation, how much ever fluid you are given, that is the amount. It doesn't depend on exactly how much amount. Insulin in hyperosmolar, they insulin in HHS, that is basically you're not giving the insulin. You give the insulin only if this criteria is satisfied. Otherwise, do not give the insulin. That is, there is slight amount of ketones are present or the glucose is not dropping. Just giving and fluid itself is sufficient for the glucose to drop down. If the glucose are still not dropping in spite of giving IV fluids, at this rate, that's when you think of starting the insulin. Otherwise, you're not starting the insulin at all. So if the patient is hypoglycemic and presents with the shock, I don't understand what this question. Still, hypoglycemia needs to be treated. Shock needs to be treated separately. Unlikely a patient with a shock will have an hypoglycemia. Why? Shock. Shock. What will happen if the patient is in shock? Counter-regulatory hormones will increase. What are the counter-regulatory hormones? What you are having? There is decrease in insulin levels and increase in cortisol levels. Both of this will what cause? Both of this will cause increase in glucose levels. So do not start assuming things. In adults, you can start immediately, but usually we give 1 liter of fluid bolus before we start the insulin infusion. If you're asking about the adults for the insulin infusion, you start after giving 1 liter. That is after 1 hour. We usually give 1 liter over 1 hour. Then you start on the insulin infusion. We do not immediately start on the insulin infusion in the adults. So we'll go to the next is adrenal glands. Adrenal glands, little bit of anatomy. Very briefly, we are touching the anatomy here. Has 3 zones. The outermost layer is known as glomerulosa. The middle layer is known as fasciculata. The innermost layer is known as reticularis. You can remember it as GFR, where G stands for glomerulosa, F stands for fasciculata, R stands for reticularis. G secretes mineralocorticoids, F secretes glucocorticoids, R secretes androgens. Cushing's syndrome. Cushing's syndrome means high level of cortisol. If high level of cortisol is present, there are two more main reasons. Either it will be primary Cushing syndrome or it will be in secondary Cushing syndrome. In an primary Cushing syndrome, what has happened? In primary Cushing syndrome, there is wrong with the adrenal gland, mainly because of adrenal adenoma. There is increased amount of cortisol which is secreted. Due to the increased amount of cortisol which is secreted, there is negative feedback mechanism to your brain, mainly to the pituitary gland, resulting in low ACTH values. So in a primary Cushing syndrome, you will be seeing low ACTH values and high cortisol levels. In and secondary Cushing syndrome, what you'll be seeing in secondary Cushing syndrome, your pituitary gland is secreting high amount of ACTH. So ACTH values will be on the higher side. That will cause stimulation of the adrenal gland, resulting in high amount of secretion of cortisol also. So both the ACTH and cortisol levels will be on the higher side. The high values of ACTH might not be only because of increased secretion from the pituitary, might be sometimes from an ectopic source, especially from the cancer. Small cell carcinoma. Small cell carcinoma of the lungs is one of the commonest cause for ectopic secretion of ACTH. How to differentiate the increased amount of ACTH is from the pituitary gland or that is from that of the ectopic secretion. What you can do is you can give large amount of steroids to the patient, that is dexamethasone. This is known as high dose dexamethasone suppression test. Give large amount of steroid to the patient, then recheck the ACTH values. If the ACTH values still remain on the higher side despite giving large amount of steroids, then it is an ectopic source for ACTH. After giving large doses of dexamethasone, if ACTH values are come down, then it is an pituitary adenoma what you need to think of. If the pituitary adenoma is the cause for Cushing's syndrome, then it is known as Cushing's disease. So the Cushing's disease and Cushing's syndrome's slight amount of changes are present. What are the symptoms usually they present with? Fat deposits. When you see, look at the patient, you can see that abnormal fat deposit over the abdomen, over the upper back, and some moon type of face they will be having. Along with it, there is increased reabsorption of calcium, resulting in hypercalcemia, and bones becomes very brittle. So osteoporosis is very commonly seen. Muscle wasting are seen. So legs and upper limbs and the lower limbs looks very thin. Sometimes some purple color striates can be seen because of the fat deposit in the abdomen, causing skin stretching, resulting in purple striae. Hypertension is one of the commonest presenting complaints in Cushing's syndrome. In females, you can see amenorrhea. In males, you can see erectile dysfunction. What are the metabolic disorders you can see? Hyperglycemia and hypokalemia. These are the important metabolic disorders which can be seen in Cushing's syndrome. Adrenal crisis. Adrenal crisis, we are talking about crisis here, not Addison's disease. First, let us see Addison's disease. Adrenocortical insufficiency is nothing but Addison's disease. Okay, most commonest cause for Addison's disease is autoimmune adrenalitis. So autoimmune disorder is the most commonest cause for Addison's disease. For adrenal crisis, most commonest cause is exogenous steroids which have been suddenly stopped or suddenly reduced. For example, someone is taking a prednisone of 80 mg for last 2 weeks and suddenly you stop it, can result in an adrenal crisis. There are other various factors which can result in an adrenal crisis like an infection, trauma, myocardial infarction, stroke, asthma, hypothermia, alcohol. So basically what is happening? Someone who has an Addison's disease cannot secrete enough of cortisol. Because enough of cortisol, that is enough of steroids, it cannot produce it. So in a stressful situation, you need enough of steroids. This in stressful situation, these are all infection, trauma, stroke, asthma. These are all stressful situation for your body. In this stressful situation, your body is not able to secrete enough cortisol because of the Addison's disease. At that point of time, this patient will go into shock. Okay, the steroids are required to maintain the blood pressure. Okay, so it will go severe hypotension, not even responding to the fluids and the even inotropes. Fluids and inotropes, they'll not respond at all in Addison's disease. Remember that if any in the stem of the question they give, the patient is not responding to the fluids and to the inotropes. The BP is not picked up at all. Think of Addison's disease. Think of adrenal crisis might be happening. Use steroids. This is included in latest guidelines for the sepsis, which we'll be learning in the next class. So he comes and presents with a profound cough, so severe hypertension, reflex tachycardia, reflex vasoconstriction, renal failure are very common things which usually they present with. What are the lab diagnosis? Lab diagnosis, the important one is the potassium will be on the higher side or in the higher margin side. For example, it will be 5.5, 5.6 in that range. Sodium will be on the lower side. For example, 130, 128 in that range it will be. So potassium and sodium will be in the opposite directions. So you need to remember sodium and potassium are in the opposite directions. The other way to remember is three things go down, three things go up. Three things which goes down are sodium values, blood pressure, and glucose values. Three things which goes up are hyperkalemia, that is potassium values will go up, calcium values will go up, and hyperpigmentation is commonly seen. In ABG also, there is a classical finding. Whenever you get an ABG, there is a metabolic acidosis with normal anionic gap. If you remember the nephrology chapter, I said you remember few things for the normal ionic gap. One of the causes for normal anionic gap metabolic acidosis is Addison's disease. Others are like diarrhea using carbonic anhydrase inhibitors. So those are the other causes, but this is the most important cause. What you need to remember: someone who has a metabolic acidosis, normal anionic gap, Addison's disease to strike in. How do you manage this patient? Manage this patient by giving steroids. There are two protocols of giving steroids. Either you give an bolus of 100 mg, then followed by 200 mg infusion over 24 hours, or you keep giving 50 mg of hydrocortisone every 6 hourly. These are the two protocols. Usually, the first one, what you need to remember, very commonly used. Okay. After this, you start resuscitating them with the fluids. Just fluids, the blood pressure will never pick up. Fluids plus inotropes, blood pressure will not pick up. Steroids are required. So the first step always is to use steroids in an adrenal crisis. Primary hyperaldosteronism, also known as Conn's disease, also known as bilateral idiopathic adrenal hyperplasia. How do they present with? Usually they present with low potassium values, high sodium values. This is opposite to Addison's disease. Remember, Conn's is opposite to Addison's. So electrolyte abnormalities, what you see in Addison's is exactly opposite here. So hypokalemia, low potassium values will be having, and high sodium values what you'll be having, along with uncontrolled hypertension. Here it was hypotension. Here it is hypertension. Same thing can be seen in renal artery stenosis, but renal failure will be there along with it. So it is easy to pick it up. How do you treat it? Initially, we treat it with spironolactone. We treat it for a month's time. Then usually we go for a surgical resection of the hyperplasia, what is present. The adrenal gland has basically in a larger size and producing large amount of hormone here. So you're kind of removing the adrenal gland itself partially. Pheochromocytoma. Pheochromocytoma is basically a tumor of adrenal gland, which basically end up secreting large amount of metanephrines. That is basically adrenaline and noradrenaline. Large amount of this gets secreted into your bloodstream because these are secreted in a pulsatile manner. It is not secreted continuously. It is not pulsatile manner. It will come. So it will be on the higher side, comes low, high, low, high, low. In this wave, it will be going. Because of this, these patients will have symptoms which are episodic. So remember, these symptoms are episodic, not continuously. So episodic headaches, and whenever they are having these headaches, if you check the blood pressure, it will be on the very much on the higher side. This is the classical presentation of a pheochromocytoma. In emergency department, what is our main role? Our main role is there is high blood pressure. Is there an end organ injury? What we are looking out for. Similarly, what we learned in the cardiology chapter, whenever a patient comes with a significantly high blood pressure, we always look for there is an end organ injury or not. For example, is there anything wrong in the eyes? Or is there a is there an hypertensive encephalopathy is present? Is there an acute kidney injury is present? Is there a myocardial infarction or a pulmonary edema is present because of high blood pressure? If yes, then you intervene and treat. How do you treat it? You treat it with phenoxybenzamine, which is an alpha blocker. This is the preferred alpha blocker because it is a non-competitive antagonist. There is another alpha blocker, phentolamine. It is a competitive antagonist. It doesn't act as effectively as an phenoxybenzamine. If phenoxybenzamine is not given in the options, that's when you are choosing an phentolamine. Otherwise, always choose an phenoxybenzamine. What about beta blockade? Do not block the beta blockers. Do not block the beta receptors. If you block the beta receptors, for example, there is increased secretion of adrenaline, which usually acts on both the receptors, alpha and beta receptors. Mainly on the beta receptor, it will be acting initially. So if you block this one, all the effect will go towards the alpha receptors. Alpha 1 receptor causes severe vasoconstriction. So reflex hypertension will develop because of severe vasoconstriction. That's why you need to give an alpha blocker before you give an beta blocker. That is an important point what you need to remember. Another thing is most sensitive test is to get a metanephrine, plasma metanephrine assay done, followed by you are getting a CT scan, CT abdomen done to see the tumor, where is it exactly. This is mainly for the chronic management. These results or these reports will not be immediately available in the emergency department. From emergency point of view, look out for high blood pressure associated with end organ injury. If present, treat the high blood pressure. Preferred drug is phenoxybenzamine. If that is not available, phentolamine you need to be giving. Never give a beta blocker before an alpha blocker. Nelson's disease. What happens in Nelson's disease? In Nelson's disease, because of Cushing's disease, Cushing's syndrome, adrenal glands are removed. So adrenal glands are for some reason are secreting more cortisol, so you want to remove it and you have removed it. over years, I'm talking about decades, like 10 years, 20 years, 30 years, due to negative feedback mechanism, because there is no cortisol in your system, negative feedback mechanism eventually will result in hyperplasia of pituitary, resulting in pituitary adenoma. Pituitary adenoma basically will eventually will result in very high levels of ACTH and melanin stimulating hormones. This will present usually with this will usually present with hyperpigmentation. High prolactin levels will be present because the pituitary adenoma usually it secretes large amount of prolactin. This is because of negative feedback mechanism. The pituitary has enlarged. It starts secreting all the hormones in a large amount, but prolactin will be very much on the higher side. And right above the pituitary adenoma is there is a tract, that is optic chiasma is present. Compression of the optic chiasma will result in bitemporal hemianopsia. Okay, this is known as Nelson syndrome. What we can do, we can just refer to the endocrinologist and neurosurgeons. They will take care. Hyperthyroidism. How do they present a patient with an hyperthyroidism? Usually, the metabolism is very much on the higher side. Hyperthyroidism means the metabolism is crazily on the higher side in hyperthyroidism. So what will happen? Because of increased metabolism, they will feel hungry. They eat a lot. So appetite is increased. In spite of increase in appetite, they will have an weight loss. This is the classical presentation. Because their metabolism is so high, they cannot tolerate heat. Because of the metabolism, large amount of heat is already produced in your body. If there is in a warm environment, if you ask them to go, they refuse to go it because they cannot tolerate it. They can tolerate the cold very well. Heat, they cannot tolerate well. This is how an hyperthyroidism usually presents with. Exactly opposite to it is the hypothyroidism, how they present to the emergency department. Hyperthyroidism, appetite has reduced. Can't eat anything, a doctor, but I'm significantly putting on the weight. Okay, weight is putting on, but appetite is decreased. So exactly opposite. Heat tolerance is okay, but they cannot tolerate the cold at all because they cannot increase their body metabolism to tolerate the cold. That's what you need to remember. Thyroid hormone is required for your body metabolism. Hyperthyroidism, increased metabolism. Hypothyroidism, decreased metabolism. Now let us see different causes for hyperthyroidism. One of the important and most commonest cause for hyperthyroidism is the Graves' disease. In Graves' disease, antibodies, your auto antibodies, your body produces antibodies which goes and attaches to TSH receptors and stimulate your thyroid hormone. Stimulation of the thyroid hormone will result in a diffuse enlargement of the thyroid gland. Along with it, there will be some amount of proptosis and there will be some amount of exophthalmosis. Those are the classical features what you'll be seeing in an Graves' disease. Enlarged thyroid gland is also known as goiter, uniformly enlarged thyroid gland, goiter. Drug induced whenever they take iodine, or it can be amiodarone related. Also, amiodarone is a drug, antiarrhythmic, very commonly used, especially for atrial fibrillations. For chronic management, amiodarone is used. Those persons also can develop hyperthyroidism. Some infections, like in subacute infection of the thyroid gland, subacute thyroiditis can be there, or some bacterial infection can lead to increased thyroid hormone production. Second most commonest cause for hyperthyroidism is toxic multinodular goiter. So multiple nodules are present, toxic, and it produces high amount of hyperthyroid. If there is a single nodule is present, then it is a toxic adenoma. It is known as think of an malignancy. Sometimes surgical manipulations or high doses of exogenous thyroid hormones can assume an hyperthyroidism state. Thyroid storm, what we are worried about more than the hyperthyroidism. Hyperthyroidism is mainly managed by the GP or the endocrinologist rather than the emergency physician. We are worried about thyroid storm. In thyroid storm, there are general causes or thyroid specific causes for the thyroid storm. General causes like an infection, trauma, or surgery, or preeclampsia, or acute medical conditions. Any acute medical conditions can trigger an thyroid storm. Thyroid specific, high doses of iodine they are taking or radioactive iodine they are taking. Abruptly, they have discontinued antithyroid medications. Thyroid hormone overdose they have done, or there is direct injury to the thyroid gland resulting in spillage of this hormone into the bloodstream. There is a scoring system which is existing, which classifies into highly suggestive, impending storm, or unlikely. You need to just remember the components of the scoring system. You need not remember the entire scoring system. Is quite complicated. So the scoring system includes temperature, cardiovascular dysfunction, CNS dysfunction, GI effects, and precipitating history. Management wise, Management wise, the main parameter what you need to remember is the mainstay of the treatment is a beta blocker. Out of all the beta blockers, propranolol is the preferred beta blocker. Why? It prevents the peripheral conversion of T4 to T3. T3 is the active form of thyroid hormone. Okay, so it has a dual actions. So it prevents or basically blocks the beta receptor effects of the thyroid hormones. Along with it, it prevents the peripheral conversion of T4 to T3. So first drug is to give propranolol. Propranolol can be given even orally, around 60 to 80 mg can be given, or intravenous form also it is available, you can give it. Second step is to give anti-thyroid medications like propylthiouracil. There is another anti-thyroid medications which is known as methimazole, which is known as methimazole. You can use either one of this, but the preferred one is propylthiouracil because again it has an additional effect of preventing peripheral conversion of T4 to T3. After 1 hour of starting propylthiouracil, that's when you are adding an iodine. Do not immediately add the iodine. If you immediately add the iodine, there will be increased production of the thyroid hormone. You need to wait at least 1 hour after giving anti-thyroid medications to add up an iodine. That's all you need to remember. The rest of the things is mainly for the practical purpose. There are different methods by which we treat this patient. We might prevent the peripheral effect of the thyroid hormone by giving beta blockers like propranolol, or you can give steroids like hydrocortisone and dexamethasone. Inhibit the thyroid hormone synthesis mainly by antithyroid medications like propylthiouracil or methimazole. Propylthiouracil preferred. Iodine is given after 1 hour of starting the propylthiouracil. Treat the underlying cause what is present. Aspirin stop in the meanwhile during the acute thyroid storm. Okay, do not give it while he's having a thyroid storm and aspirin. Just hold it back. Once you treated the thyroid storm, then after an hour's time, you can restart the aspirin. 75 mg, for example, he's taking for MI. He's known case of IHT, or recently he had a myocardial infarction, so he's on aspirin. You can give the aspirin, but do not give it in the acute state. Once the acute state is passed, then restart the aspirin. Propranolol can be given in various doses. Alternative is ismolol, that is not available. Metoprolol can be used. Metoprolol, if not available or contraindicated for reasons, even and calcium channel blockers like verapamil can be given. Myxedema coma. This is a complication of hypothyroidism. Whenever they want you to test you on myxedema coma, few things you need to keep it. In the history, they might directly mention that this patient has an hypothyroid. So look out in the past medical history of hypothyroid, they are mentioned or not. Or they can mention that there is an waxy induration which is seen over the shins of the lower limbs. Okay, look out for these two important terms. Along with it, then add up with the history what they have given. If you just read the history, you might get completely confused. Look for key terms like hypothyroidism. Look for waxy induration. Have they mentioned these two key terms? Along with it, is usually seen in an elderly person who has an altered sensorium. So one criteria is GCS is on the lower side. So some alteration of the sensorium, is agitated or confused or might be comatose even. Look at the temperature. Usually they will be hypothermic. In certain conditions, the temperature might be in the normal range. Normal range, why? Because there is significant of infection is present. When there is significant of infection is present, we usually suspect this patient to have an fever, that is high temperature. In spite of having significant infection, this patient doesn't have an fever. High temperature is not there. At that time, it will be in the normal range. That is the second criteria. The third criteria is there is an precipitating factors. Most of the time, the precipitating factors is an infection, followed by cold exposure, especially seen in winter times. Sometimes it might be an infarction or GI bleed. So any stressful situation is there, it can predispose because it is required for increased metabolism. Increased metabolism is not there, resulting in myxedema coma. So this thyroid hormone is deficient, so you are giving the thyroid hormone replacement. That is the step 1. Step 2 is giving steroids. Step 3, treating the underlying cause. And basically supportive management, if required, whatever is required, you will be giving. Remember that this is an MCQ exam what you are giving. In the last diet, what had happened, they had not mentioned the thyroid hormone at all. They had given hydrocortisone. So you'll choose the most appropriate option. Don't stick to thyroid hormone is not given. I don't know what you've done. Go to the second most appropriate option. What is the second in line of the drug what you're giving? Hydrocortisone. Choose hydrocortisone in the exam. They will get a mark. That's how your thought process should go on. It is the best out of the options what they are given. They are asking you to choose. They are not asking exactly perfect answer there. It may not exist in the options. Then you need to go to second most appropriate answer for this question or for this Second most appropriate answer for this question, whatever is there, you are picking it up. Pituitary apoplexy. What is apoplexy? Sudden blood loss. Sudden blood loss, it might be because there is a block and infarction has happened, or there is an hemorrhage which has happened. Okay, sudden blood supply to the pituitary is gone because of an hemorrhage or infarction. It is known as pituitary apoplexy. Pituitary apoplexy itself means hemorrhage or an infarct. How does this hemorrhage or infarct can happen? Because of a trauma, because you're taking anticoagulants, some radiotherapy to the pituitary gland, you're given some adrenaline stimulation drugs like high doses of dextrose and all they are given. Sjogren's syndrome is an interesting one, which is usually seen in postpartum period. Okay, little bit about the Sjogren's syndrome, commonly seen in postpartum women. What happens in postpartum? Usually what happens in pregnancy? Pregnancy, there is one more living thing in your body, that is, an fetus is present. Because of that, pituitary gland gets stimulated, more hormones need to be secreted. So pituitary hyperplasia is there. Pituitary gland has enlarged in size. Okay, when it enlarges in size, the blood requirement will go high because it is a large size organ, so it requires more blood. In postpartum period, that is during the delivery, if there is a postpartum hemorrhage, what will happen? Sudden loss of blood is there. So the blood supply to the pituitary will fall down suddenly. This will cause infarction. This results in pituitary apoplexy known as Sheehan's syndrome. What will happen in pituitary apoplexy? There is some pathology in your head because it is a pituitary organ is inside your head. So they'll have headache, nausea, vomiting, photophobia can be seen because optic chiasma is right above the pituitary gland. It has enlarged in size, can cause visual disturbance. So bitemporal loss of vision will be seen. All right. So this vision defect you need to remember. Investigations wise, you are getting an urgent MRI scan done along with the hormones you are getting it done. The most important one is the getting the prolactin levels. This is the hormone what is very important. This is the one which gets elevated at the initial stages, especially in pituitary adenoma also. So anything related to the pituitary gland you are worried about. For example, pituitary adenoma, get a prolactin level done. That should be the first hormone level what you are getting it done. Imaging is always you get it done in a later stage. You are treating as airway, breathing, circulation, deformity, mainly the supportive management. Involve the surgeons. You're giving an hydrocortisone 100 mg stat dose. Diabetes insipidus. What is diabetes insipidus? First, little bit of physiology. That's why we can understand better of diabetes insipidus. Here, what happens? The pituitary gland secretes antidiuretic hormone. Antidiuretic hormone. That means it has to retain the water. It doesn't cause diuresis. That means increased urine is not produced. Antidiuretic hormone it is. So it retains the water. So antidiuretic hormone acts on the kidneys, resulting in retention of the water. In diabetes insipidus, what happens? This retention of water is gone for two reasons. It might be increased production of ATH hormone known as cranial diabetes insipidus, or this ATH hormone is secreted in the normal amounts itself. Sorry, there is decreased amount of secretion of antidiuretic hormone. Okay, because there is a decreased secretion of antidiuretic hormone, this patient is urinating a lot. So there is something wrong in the brain. That's why it is known as cranial diabetic insipidus. Nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus, the amount of ADH which is secreted is normal itself. Okay, it is normal. It is going and acting on the kidneys, but it is not effective on the kidneys at all. Okay, somehow this antidiuretic hormone is not effective on the kidneys, resulting in increased urination. This is known as nephrogenic diabetes insipidus. Most of the time, we encounter a nephrogenic diabetes insipidus in the emergency department because of an electrolyte imbalances like low potassium values, high calcium values, drugs like lithium, kidney infections, or accumulation of the urine in the kidneys, polycystic kidney disease, or inherited. This causes are very important because whenever we see increased urination, we think of a diabetes insipidus nephrogenic cause. Are there any electrolyte imbalances? What we need to really look out for. Cranial, it can be because of an head injury, meningitis, pituitary tumors, craniopharyngiomas, idiopathic or vascular lesions can be there. Most of the time, cranial diabetes insipidus usually do not present to the acutely to the emergency department. It's the nephrogenic diabetes insipidus which presents acutely to the emergency department. So high amount of urine or large amount of urine is produced. So urine output is drastically increased. If the urine, there is large amount of water loss is there, urinary sodium or urinary osmolality will be very much on the lower side. Because intravascular volume is lost in the urine, plasma osmolality will go on the higher side. Serum sodiums will be going on the higher side because he's severely dehydrated because of the increased urine production. So this is the classical signs what you'll be seeing in the laboratory investigations. Do not forget to check the potassium values and the calcium values because they are one of the causes for nephrogenic diabetes insipidus. If you're thinking of a cranial cause, get a CT scan done. Measure other pituitary hormones also like TSH, LH, FSH, prolactin levels. Two important investigations you need to remember. One is water deprivation test. Whenever you do not drink, urine gets concentrated. In diabetes insipidus, in spite of water deprivation, urine doesn't get concentrated. So you know it is in diabetes insipidus. How do you differentiate between nephrogenic and a cranial? What you do is in a diabetes insipidus patient, you give an ADH hormone. Then you see what happens. Once you give an ADH hormone, if the urine becomes concentrated, that means something is wrong in the brain. So it is an cranial diabetes insipidus. In spite of giving ADH, urine remains same. It doesn't get concentrated at all. The osmolality will be on the lower side itself. That suggests that something is wrong with the kidneys. In spite of giving ADH hormones, there is no antidiuresis. There is no concentration of the urine. So it is a nephrogenic diabetes insipidus. Treatment for cranial, we give desmopressin intranasally 1 microgram. Nephrogenic, we treat the underlying cause. The mainstay of the treatment in the emergency department is to make sure they are hydrated. So catheterize the patient, measure the urine output. The input and output chart needs to be maintained and they should be at least equal. Okay, this will make sure the patient doesn't get dehydrated. Sodium values. Sodium values are on the higher side because of the dehydration. As we learned in the last few chapters that hypernatremia main cause is because of dehydration. Here also this is dehydration. You giving fluids will treat the hypernatremia. Nothing special needs to be done for the sodium. Syndrome of inappropriate ADH secretion. So inappropriate amount of antidiuretic hormone is secreted. So large amount of water is retained by the kidneys into your circulation, resulting in what? Dilutional hyponatremia. Low levels dilutional hyponatremia will result. Usually most of you end up asking why not dilutional hypokalemia also can be resulting in this patient. Doesn't happen. Why it doesn't happen? Because potassium values are very much less extracellularly. What we are looking is extracellularly. Extracellular potassium values are less. They are in single digits. Usually it is 3.5 to 5.5 is the normal range. But the sodium values are in the large amount. Okay, so it is 135 to 145 is the normal range. Normally in the most of the labs, it is the normal range what you are having. So if it reduces even by 10%, here it goes away from the normal range. Here, if it reduces by the 10%, still it remains in the normal range. That's why no effect is seen on the potassium, only the effect is seen on the sodium per se. That's why you're only seeing an hyponatremia. Urine, there is significant loss of sodium will be seen in the urine and urine osmolality will be increased. Why urine osmolality is increased? Because it is very concentrated urine. Syndrome of inappropriate ADH secretion, SIADH, can be because of any CNS cause, like in subarachnoid hemorrhage to subdural hematoma to an infection like meningitis, encephalitis, abscess formation, head injuries can cause. Malignancy, one of the most important malignancy is in small cell carcinoma, can cause paraneoplastic syndromes resulting in increased secretion of ADH hormones. Anything which is long with your lungs, like a pneumonia, infection, metabolic disorders like porphyria, drugs like opioids, and sometimes even trauma can trigger SIADH, that is syndrome of inappropriate antidiuretic hormone secretion. Treat the underlying cause is the main symptom. Asymptomatic or mild to moderate symptoms. Basically, we call it severe symptoms if the patient is having severe seizures or coma, then it is a severe symptom. Mild to moderate symptoms, just fluid restriction, what is required. Severe symptoms are because of what? Because of low sodium values. Lower sodium values, when do we treat? We have learned from our nephrology chapter, we treat it only if the patient has seizures or altered sensorium is present. If the patient has a seizures or altered sensorium, we treat it with an hypotonic saline, that is 3% saline we are treating with. These are mainly started by the nephrologists. We are not worried about. and urgent renal, that is nephrologist review, will be required in any patient whom you are diagnosed with SIADH. Ovarian hyperstimulation syndrome. Nowadays, because of increase in incidences of infertility, IVF has become very common. In vitro fertilization has become very common. That's where the couples are going so that they can have a baby. So what happens, what they do in an IVF, they give external hormones, various kinds of external hormones they'll be giving, hyperstimulate the ovaries so that large amounts of eggs can be collected and they can be fertilized in vitro. That is the basic thing what they do in IVF. What will happen if you stimulate the ovaries? Ovarian hyperstimulation can happen. One of the side effects is ovarian hyperstimulation. They will release large amount of vasoactive factors. What they do, basically what they do is they dilate the capillaries. Along with the dilatation, they become very much permeable. So the serum and the plasma can easily pass through the membranes because it is highly dilated and it becomes highly permeable. So large amount of fluids gets accumulated in the extracellular spaces, resulting in an ascites. So they gain a weight a lot. They come and say, I have gained a weight a lot. My abdomen feels bloated. My abdomen is dilated. That is basically ascites what they are having. Sometimes the fluid might be so much so high that compartment syndromes can develop. Intravascular volumes are drastically reduced, resulting in decreased perfusion of the end organs and can result in end organ failure like liver failure, heart failure, renal failure can result. Because intravascular volume is reduced drastically, it is very concentrated blood what they are having that results in hypercoagulability. So they can easily coagulate. So thromboembolisms can happen, a stroke can happen, a myocardial infarction can happen easily. This has become more and more common because IVF has become more and more common. They end up presenting to the emergency department. So we need to be aware of. So usually they will be on some gonadotropin stimulating hormones. We have already learned. Classical presentations or most common presentation is shortness of breath, abdominal discomfort. These are the two most common, followed by GI symptoms. Others are not very common. Weight gain can be seen. Rapid weight gain, abdominal discomfort, shortness of breath. Shortness of breath is basically for the pleural effusion. Fluid has accumulated into the pleural space. Investigations wise, get and full blood count done. Full blood count, hematocrit values will be on the higher side because your blood is concentrated. Hematocrit will be on the higher side. Coagulation profile, hypercoagulated state because the blood is again concentrated. So PT, APTT, INR and bleeding time, clotting time will be on the lesser side. Hypercoagulability state will be there. WBC counts might be on the higher side, as high as 22,000, higher than 22,000 it might be. Don't think of an infection. This basically suggests that how severe is the ovarian hyperstimulation syndrome these patients are having. Kidneys and kidneys and livers, these are the end organs which can get affected. Do get them. Electrolyte abnormalities can also be seen. For that reason, kidney function test, liver function test, and electrolytes are the investigations what you need to get it done. Treatment wise, mainly it is symptomatic treatment. Nothing special is there, nothing specific there what you can do it. They usually recommend or suggest or emphasize on intervening as soon as possible. Sometimes they can develop ovarian torsion, ovarian hemorrhages, intervene surgically as soon as possible. Sometimes the ascites might be so much so significant, cause compression on the IVC and diaphragm, so do ascitic taps. Sometimes there might be a significant amount of pleural effusion resulting in shortness of breath and low saturations. Then you might have to put an ICD. So basically, you're treating the underlying cause. Symptomatic treatment, what you need to remember, there is no specific treatment for ovarian hyperstimulation. So before I go into the recalls, let me go to the questions what you are having. High dose dextrose, high dose, not dextrose, it's a dexamethasone steroid what you are giving. Steroids. Okay. If I have mentioned it as a dextrose, it is wrong. It's a dexamethasone, high dose steroids what you're giving, not dextrose, dexamethasone. So in ER, we will rely on signs and symptoms to identify the hypertension emergency due to pheochromocytoma. Yes, you are basically hypertensive emergency what you are looking out for. You will not be able to diagnose and pheochromocytoma in the emergency department. You can guess it by the episodic hypertensions what they are having, episodic headaches what they are having. You cannot pinpoint and say this is a pheochromocytoma because metanephrine is the most sensitive lab investigations. You will not be immediately available to the metanephrine levels. So all this cannot be diagnosed in the emergency department. What you are seeing, hypertension emergency, if present, you're treating hypertension emergency. Suspected case of pheochromocytoma, you will mention in your records and admit the patient. So beta blockers or hydrocortisone, anyone can be given in thyroid storm. Beta blockers is preferred, especially propranolol is preferred. Steroids are not preferred because beta blocker, propranolol, especially the propranolol, can prevent the peripheral conversion of T4 to T3. That is the inactive form to active form conversion. It can stop or it can prevent it. For that reason, beta blockers are preferred. Steroids are not preferred. Another reason for the steroids is not preferred is it doesn't immediately act. It takes hours to get it to the act, even though if you give it intravenously in the thyroid storm. That's why beta blockers are the preferred ones. So beta blockers first you are giving, followed by propranolol, specifically propranolol, beta blocker, what you are giving. After that, antithyroid medication, that is profile-thiouracil, what you are giving. Wait for an hour's time, then you are giving iodine. That's all you need to remember in an thyroid storm treatment. Let's enter into the recall questions what we are having, which have appeared in the previous stats. So the first one is a 22 years old male has presented to the emergency department who is a known case of insulin-dependent diabetes mellitus to the emergency department. Complaints of abdominal pain. He gives an history of polyuria, polytrypsia, and weight loss since a few weeks. Intravenous exercise has been obtained and blood is collected for investigations. Lab investigations they have given. They are just asking what is the anionic gap in this patient. We have already learned about the anionic gap in this patient. So we are not learned in this chapter. We are learned in the previous chapters. That is in the, if I'm not wrong, in nephrology, what we are learned about. So in nephrology, we are learned what is the formula for the anionic gap. So sodium plus potassium, okay, minus chloride plus bicarb. So this is the formula. So sodium, they are given 135 plus potassium, they are given 4.2 minus 95 plus 6, what they are given, that is chloride plus bicarb. So it will come, if I'm not wrong, 139.2 minus 101. So it will come 38.2. So the right answer will be 38.2. So remember the formula. Formula is important here to remember. So it comes as 38.2 approximately if you calculate it. A 30 years old female present to the emergency department with palpitations, restlessness, diarrhea since last to 2-3 days. And she has no comorbidities, is not on any prescribed medications, takes OCP regularly. Observations are given. There is a tachycardia which is present. There is ECG shows sinus tachycardia. Next image has been given here, shows and goiter, a diffusely enlarged thyroid gland is shown. Keeping all this point, we are thinking of an hyperthyroidism. And more specifically, we're thinking about this might be an thyroid storm because significant tachycardia is present. It is 140, which is very significant. What we do, initial management, propranolol, beta blocker, what you're giving. So fifth option is the right one here. We have in middle age male who was found collapsed on the road, brought to the emergency department by the police. He is a known alcoholic with multiple previous visits to the emergency department. You have secured the IV line and collected the blood for the investigations, and these are the lab values. There is certain amount of acidosis is present. It looks like a metabolic acidosis with respiratory compensation, what is present. Electrolyte seems grossly on the normal side. What type of fluid is suitable for this patient? For this patient, initially, it is better to give an thiamine because he is a known alcoholic. Okay, initially give a normal saline, followed by you can give an dextrose if required. Here, there is no indication for dextrose to be given because the sugar values are on the higher side. That's why we prefer giving thiamine and normal saline should be sufficient. So thiamine and normal saline is the best one fluid what you can give to this person because he is an alcoholic. Any alcoholic who comes to the emergency department, we give thiamine, what you learned in the last class. Along with it, what fluid we can give because he's not, if he was hypoglycemic, I would have chosen and dextrose. If he's not hypoglycemic, that's why I'm choosing a normal saline. Just plain normal saline can be given, but thiamine is always recommended to be given anyone, or plain heart meth also can be given. But thiamine, who is a known alcoholic, always give thiamine when they present to the emergency department, no matter for what reason. A 30 years old female present to the emergency department with a sore throat and a lesion in the oral cavity. She denies any fever or cough, no similar complaints in the past. She's on regular. This medication is important. Remember carbimazole. Okay, carbimazole, she's on the regular tablets. No recent changes in the medications. Vital parameters are stable. What is the investigation of the choice? This carbimazole, remember there is an side effect of this carbimazole. Notoriously, it causes agranulocytosis. Okay, so Agranulocytosis, absolute eosinophil count will be less than 100 here. Absolute eosinophil count will be less than 100. This predisposes to an oral lesion known as necrotizing stomatitis. I'll be showing the image how it appears in coming up slides. So this causes necrotizing stomatitis. So to know whether this patient is having an agranulocytosis because the patient is on carbimazole, it's better you get a full blood count done with the differential counting because you're looking at the neutrophil absolute count. So the right answer here is the first one. A 33 years old female presents to the ED with complaints of abdominal discomfort and lethargy. Recently, she has undergone an ovarian stimulation. Whenever they say recently IVF or ovarian stimulation, think of ovarian hyperstimulation syndrome, OHS. Always think of this, very commonly can be tested in the exam. They're asking which one of the abnormalities cannot be found in this patient. Impaired LFTs can be seen because end organ injuries like liver and renal are very common. Hypoproteinemia can be seen. Okay, hypercoagulability, yes, can be seen. High WBC counts, yes, can be seen. Hematocrit on the lesser side, no. Hematocrit values are usually on the higher side. So the right answer here is the first one. So this is the oral lesion what I was talking about. Okay, this is necrotizing stomatitis. The patient is on carbimazole. Whenever they are on carbimazole, always think of agranulocytosis. Because of agranulocytosis, this patient can get predisposed to necrotizing stomatitis. This appears in this manner. So get a full blood count to see agranulocytosis is present or not. So the right answer here is the second one. A 79 years, so elderly we are having, along with an hypothyroidism, IHD, and osteoarthritis, was brought to the emergency department from a care home in an ambulance, and she complains of confusion and lethargy since few days, which is worsening. She's on antibiotics for an urinary tract infection. Her heart rate is on the higher side. Tachypnea is present. Blood pressure is fine. Temperature is also fine. Acidosis can be seen with very high lactate levels. Acidosis with very high lactate levels and there is an infection. So I'm thinking there might be a sepsis or severe infection. In spite of severe infection, this patient temperature is in the normal range. Infection precipitating factor is present. Altered sensorium is present. Keeping all these three parameters in mind, the normal temperature in spite of high temperature, in spite of an sepsis, there is precipitating factor. Here, precipitant factor is sepsis. So one parameter, two parameters, and the third parameter is altered sensorium. This is basically myxedema coma, what we are talking about. Because this patient is also an hypothyroid, all goes in favor of myxedema coma. How can you diagnose this? Get a thyroid profile done. That is TSH, T3, and T4 levels. A 78 years old male, unknown case of CA lung is brought to the ED in an ambulance. Carer says that he has an altered sensorium since couple of days. You have connected the patient to a cardiac monitor and collected the bloods for investigations. His observations and labs are as follows. They have given where one abnormality very striking is the sodium values on the very much lower side. Rest of them are grossly normal. What is the next best step? You need not even think twice here and see what is happening here. What do you see? Low sodium values are there, plus altered sensorium is present. Okay, that should be triggering you, or you should go ahead and treat this patient with a 3% saline. So basically, the answer is very easy to answer in this manner. But let us understand what exactly is happening in this patient. There is an CA cancer. CA cancers are very commonly known to secrete more ADH hormone, syndrome of inappropriate antidiuretic hormone secretion. This most commonly causes low sodium values. That's why this patient is having a low sodium values. What we do, if the low sodium values along with it, if the patient is having a seizure or an altered sensorium, we treat them with the hypertonic saline. Otherwise, we usually restrict the waters. We think that it is mild to moderate symptoms. Water deprivation will be there and we'll admit. For that particular reason, we are giving 3% saline. Hydrocortisone, we are not giving at all. We are not thinking of anything which requires a steroid here. Okay, fluid restriction, we would have done it if there was no altered sensorium. Altered sensorium is present. That's why we are giving hypotonic saline here. This is a diagnosis of syndrome of inappropriate ADH secretion. A 34 years old female present to the emergency department with complaints of a low-grade fever since 2 to 3 days. This is generalized weakness, reduced appetite. She is a known case of asthma. Her regular medications includes salbutamol inhalers and prednisone. She is on steroids. You have connected to the cardiac monitor. Her observations are as follows. There is slight amount of tachycardia and tachypnea is present. Blood pressure is on the lower side or borderline, I can call it. You have secured the IV lines. Fluid and antibiotics are given according to the protocol. You can see the sodium values on the lower side, potassium values on the higher side, and glucose is borderline. BM is on the borderline, what you need to remember. What is the most appropriate next step? So what is the diagnosis? What do you need to think of? So what am I thinking of? On steroids, so Addison's disease can be there. Along with it, sodium going on the lower side, potassium being on the higher side, moving opposite to each other, BM being on the borderline. All this goes in favor of adrenal crisis. So in adrenal crisis, the first step is to give hydrocortisone. What is the dose? It is the 100 mg. Remember the dose, they might confuse you with the dose. In the exam, they had mentioned both 100 and 200 mg. It is the 100 mg what you need to remember. So the right answer is the first one. A 40 years old female present to the ED with complaints of upper abdominal pain associated with multiple episodes of vomiting and fever. She is a known case of diabetes on insulin and has stopped taking insulin because of recurrent vomiting. Her observations are as follows. So stop taking insulin for the recurrent vomiting. What do you need to remember? These are the observations what you are having. BM is on the higher side. Fever is present. pH is less than 7.3. What is present there? Okay, and they're asking which one of the following tests will help you with the diagnosis here. So BM is also, sorry, he's a known case of diabetes. So two criteria of DKA is satisfied and usually they present with severe vomiting, stop taking insulin. We need to always think of an diabetic ketoacidosis. pH is on the lower side and he is a known diabetes and the sugars are also on the higher side. So one more criteria is required. One more criteria is to look for the ketones. In the options, they are given blood ketones and urine routine. Urine routine will be helpful to see ketones in the urine also. Ketonuria can be seen. Which one is more sensitive? Ketonemia, that is ketones in the blood is more sensitive. So get blood ketones levels. They are more sensitive compared to the urine ketone levels. A middle-aged male was brought to the emergency department with complaints of recurrent vomiting and abdominal pain. He has no comorbidities, not on regular medications, has taken connected him to a cardiac monitor and requesting you to immediately review the patient. On reviewing, he has tachycardia, tachypnea, hypotension is present. Investigation values shows sodium on the borderline, potassium significantly high, so sodium on the lower side, potassium on the higher side. Now itself, I am thinking as an Addison's disease or Addison's crisis here. Along with it, hypotension is also present and glucose is on the lower side. All keeping this, you are strongly suspecting what? Adrenal crisis here. Whenever you're suspecting an adrenal crisis, you are giving an hydrocortisone. Young male present to the emergency department with complaints of lethargy and increased urination. He has not opened his bowel since couple of days. On further questioning, he says he has bone pain. His vital parameters are within normal limits. Systemic examination is unremarkable. You're suspecting and you're suspecting primary hyperparathyroidism, not hyperthyroidism. It's hyperparathyroidism. Okay, one word is missing. Hyperparathyroidism, what you are suspecting. Which one of the following is suggestive of an hyperparathyroidism? Okay, which one of this following is suggestive? In primary hyperparathyroidism, what happens? Calcium values will go on the higher side, phosphate values will go on the lower side. So which one of the following is present here? Calcium values are present. What about parathyroid hormones? It's a primary hyperparathyroidism. Parathyroid hormones will be on the higher side. Phosphate will be on the lower side. Low vitamin D is nothing related to the primary hyperparathyroidism. Calcium values will be elevated. So the right answer here is the second one. This again we have learned in the nephrology. Somehow it has missed and come up here. A nephrology question has ended up here. A 24 years old female, if in question, okay, one of you have a doubt in question 11, if glucose given in the options, should we give glucose first to manage hypoglycemia or hydrocortisone? Hypoglycemia, is it a significant hypoglycemia? That means if the glucose values are less than 2.5 millimoles per liter, then you can think of giving the glucose first rather than giving the steroid. But most of the time, the recommendation is to directly give the hydrocortisone because this patient will have hyperkalemia, hyponatremia. So those parameters also. So overall, which is the drug which can easily help this patient is the steroid. That's why the recommendation is always to give the steroid first, even though if the patient is having an hyperglycemia in an adrenal crisis. Coming back to this question, we have a 24 years old female came to the emergency department to complaints of weight loss, even though her appetite has increased. She has been eating a lot, but she is losing weight. On further questioning, she says she has increased sweating and palpitations. She thought it might be due to the warm weather, hence didn't seek any medical. On the triage nurse, the vital parameters checked. There is some amount of tachycardia is present. Rest of the parameters are fine. What is the most likely diagnosis? Weight loss in spite of eating a lot, that means in spite of increasing appetite, is suggestive of an hyperthyroid or hyperthyroidism. Similar question had appeared in last date also September 24. A 8 years old kid was brought to the emergency department by a worried mom. She says that she's been vomiting a lot and not eating anything since yesterday. This morning, she has noticed that the kid is very drowsy, hence immediately rushed to the ED. You received the kid in the resuscitation bay and connected to the cardiac monitor, got a blood investigations done, and these are the blood investigations what you are having. pH, acidosis is present, so the pH is less than 7.3. Bicarb is also less than 15. What is the most likely diagnosis in this patient? They're asking. BM is also on the higher side. So BM on the higher side with an acidosis, think of an DKA, especially in pediatric age group. Especially in this age group, it is an undiagnosed type 1 diabetes mellitus. This is the initial presentation to the emergency department. That's why he has presented with complications. Remember that DKA is more commonly seen in type 1 diabetes. HSS is more commonly seen in type 2 diabetes mellitus. So the right answer here is the second option, DKA. A 55 years old male walked to the ED with complaints of increased urination lethargy, which has been worsened since morning. He is unable to carry out his regular activities. The triage nurse has received the patient in resuscitation bay as he looked sick and requesting to be immediately seen. And his regular medications for the diabetes includes the sitagliptin and metformin. The observations are tachycardia, tachypnea. Rest of the things seems to be fine. Sodium values uh, slightly on the higher side. Potassium is in the normal range. Creatinine is increased. Glucose values are significantly increased. It is more than 30 millimoles per liter. Ketones not significantly increased, but slightly increased is there. What is the next best step for this patient? What are we suspecting in this patient? We are suspecting an HS because the glucose values are on the significantly higher side. Along with it, let us calculate the serum osmolality. 2 times the sodium values is 148, plus the potassium values what they are given is 4.2, plus the urea values they are given as 9.5, plus the glucose values they are given 41.6. If I am not wrong, if you calculate it, this value will be obviously more than 320. Anything osmolality more than 320, it is an HSS for you. So this is an HSS what you are having. HSS, how do we treat it? Fluids is the mainstay. Give IV fluids. Do not give insulin in this patient. Insulin, there is a criteria when to start it. Most of the time, insulin will not be required in HSS. Mainstay of the treatment is fluids. A 49 years old male, a known case of diabetes, presented to the emergency department with complaints of multiple episodes of vomiting and abdominal pain. His regular medications includes glifoxin. I said glifoxin. Think of euglycemic diabetic ketoacidosis. Once daily, a short-acting insulin and thrice and vital parameters kind of seems to be on the normal side. pH shows acidosis. Lactates on the higher side. What is the most likely diagnosis they are asking? pH is less than 7.3 and the patient is one of these drugs. Always think of an euglycemic diabetic, diabetic ketoacidosis in this patient. Even though the glucose levels are in the normal range, even though if they are not given ketones, still think of euglycemic diabetes insipidus. No, sorry, diabetes ketoacidosis. So the right answer here is euglycemic diabetes ketoacidosis. A infant 3 years old, 3 weeks old, brought to the ED with 5 days history of diarrhea and vomiting, has vomited 24 hours on triage. He's been alert and interacting his alert. Tachycardic, dry lips are seen. Blood pressure are otherwise in the normal range. Sugar values are low 2.1. So anything less than 2.5, we treated in the pediatric age group. There is no other significant past medical history. The other household family members had recently been unwell and with similar symptoms. The capillary blood class is completely normal. What is the most appropriate next step? Treat the hypoglycemia. What is the GCS? This patient is, this kid is quite interactive, doesn't look abnormal, looks fine for you. So GCS is fine for you. So you are giving an oral supplement. Which one has an oral supplement? This one is IV access. We do not want it. This one has an oral supplement. Screening, no. Oral and give an emitop. Yes, this one has it. This one has it oral. Emitop and cannulate, no. So we are giving orally. We left with two options here, option 2 and option 4. Option 2, there is something mentioned as emitop. What is emitop? Emitop is a local anesthetic. It basically has a tetracaine. Okay, it is a local anesthetic which is usually applied over the skin in the pediatric age group so that they can easily cannulate this patient. What is more required? Does this patient requires a cannula or checking the sugar levels after 10 minutes? Checking the sugar levels after 10 minutes is more important. It's mentioned in the NICE guidelines. That's why the option 2 is most appropriate option. So select option 2. A 21 years old male was brought to the emergency department in an ambulance. He presented with an abdominal pain and drowsiness. He's a known case. He's has no known comorbidities. He's not on any regular medication. The patient received in the resuscitation bay has a low GCS. His vital parameters shows tachycardia, tachypnea, blood pressure is fine, saturations are fine. VPG shows acidosis. It's a metabolic acidosis with respiratory compensation and high lactate levels, high ketone levels. You're already diagnosed with an DKA, which is not true regarding the DKA management they are asking. Stop insulin once the ketone values is less than 4 millimoles per liter. No, that is not the right criteria. The right criteria is usually we look out for the pH. pH should be in the normal range. Okay, that is the criteria what we usually follow. Along with it, the patient should be able to take orally. If these two criteria are satisfied, that's when we stop the insulin infusion. Otherwise, we do not stop. Start 10% dextrose at 120 ml per hour once the glucose levels falls less than 14 millimoles per liter. It's a true statement. It's a correct statement. Potassium correction is only started if the potassium levels are less than 3.5. Again, false statement. We start correcting it even if it is in the normal range of 3.5 to 5.5, we still correct it. We give potassium supplements. Stop IV fluids once the blood pressure is in the normal range. No, that's not the criteria. We give fluids, a large amount of fluids is given in DKA. Decrease the insulin infusion rate if ketones remains constant. No, we increase the insulin rate if the ketone remains constant. So the right one is this one. 5 ml will not make a huge difference. It's a 120 or 125 ml will not make a huge difference. Okay. Don't beat to the dot. A 5 ml over an hour's time doesn't make much difference. Is the 120 what you need to remember. A 38 years old female was involved in a road traffic accident and head-on collision with another four-wheeler. She sustained an injury to the head and there is an history of loss of consciousness at the scene. She's been brought to the emergency department in an ambulance. On arrival, the patient's vital parameters are within normal limits. A CT scan of the brain was taken. It was normal, no intracranial bleed was there, but an incidental finding of an pituitary adenoma was seen. Which of the investigation is most appropriate? Anything wrong with the pituitary, always get an prolactin level done. Here, pituitary adenoma, what you're seeing. Diffuse and large thyroid gland. It's a goiter, what you're seeing. What is the ECG, what we are having here? No P waves are seen, an irregular rhythm, what we are having. So it is an atrial fibrillation. Two images, we already dealt with it. Let's just see the stem, what we are given. A 30 years old female present to the ED with complaints of palpitations on and off since last few days. She has been having palpitations since last few hours, which are not subsiding on examination. Basically, heart rate is on the higher side. There's tachycardia and tachypnea. Blood pressure is normal and saturations are normal. Investigation shows grossly normal. ESR slightly elevated. What's the most likely diagnosis? Diffusely enlarged goiter can cause tachycardia, sometimes even trigger arrhythmias. This patient is having an AF because of hyperthyroidism. Why hyperthyroidism? Diffuse enlarged goiter, think of Graves' disease. Multiple nodules will be there. Thyroiditis usually goiter will not be present. Single nodule will be present. Asymmetous thyroiditis doesn't present with an enlarged goiter. And the most commonest cause for the hyperthyroidism is a Graves' disease. A 82 years old female brought to the MS department and she lives in an elderly care home and carers have noticed that she has an altered sensorium. She is a known case of hypertension, ISD and a CKD and her regular medications She's been taking her regular medications. On examination, she is drowsy, afebrile, vital parameters looks closely normal, vaccine duration is seen over the lower limbs. Blood investigations shows CRP significantly high, WBC significantly high. So there is an infection what this patient is having. Along with the infection, there is an altered sensorium. So the GCS is on the lower side what we are having. Elderly person, another important point what we are having. Vaccine duration we are having. Keeping in mind vaccine duration itself should trigger that this might be an maximum coma. Supporting to this is altered sensorium, a predisposing factor like an infection and an elderly person. So what are we thinking? It's a myxedema coma. So diagnosis is myxedema coma. You are strongly suspecting an HSS. Which one of the following is an diagnostic criteria for an HSS? Osmolality should be more than 320, not 280. pH less than? No. pH should be more than 7.3. BM more than 11? No. We are thinking of BM more than 30. Ketones value more than 3. Ketones, no. No significant amount of ketones should be present. This becomes significant amount of ketones if it is more than 3 millimoles per liter. Serum osmolarity more than more than 320 millimoles per liter is the right one in the criteria. A 72 years old female presents with an hypertension, CKD and a small cell carcinoma. Present to the emergency department with complaints of generalized weakness, fatigue, weight gain, intermittent agitations are there. Medications include lisinoprolol, hydrochlorothiazide, and dexamethasone. On examination, our vital parameters are within normal limits. Was the most likely cause? You need to remember that this patient might be having a Cushing's disease because any cancer can produce an ectopic hormones, that is ectopic cortisol levels this patient can have. This ectopic cortisol levels, whenever there is large amount of fat deposit resulting in a weight gain, fatigue, and generalized weakness of the common symptoms. So we are thinking of an Cushing's syndrome in this patient as the most likely cause. Weight gain is absolutely not seen in hypothyroidism. Hypercalcemia doesn't present this. Brain metastasis, weight gain doesn't fit in. Addison's disease mainly presents with an electrolyte abnormalities with an hypotension rather than an weight gain and generalized weakness. A 72 years old female is brought to the emergency department from an care home via ambulance. The carers reports that she has been experiencing confusion lethargy for the last few days with worsening symptoms. Her vital parameters are as follows, which I'm sorry here. Okay, this is the question what we are discussing. I think we have finished. Okay, this we have already finished here. This is the Cushing syndrome. Sorry, the slide, this one. Let me read it again here so that no confusion is there. A 72 years old female is brought to the ED from a care home via an ambulance. The carers reported that she has been increasingly confused, lethargic for the past few days with worsening symptoms, and her vital parameters are as follows. Shock the patient is in. There is an hypothermia the patient is having. Vaccine induration is present. Keeping all this in mind, we are thinking of an myxedema coma this patient is having. What is the treatment for myxedema coma? Thyroid hormones, what needs to be given? There is no mention of thyroid hormones here. So the next step is to give the steroids. The first steroid is hydrocortisone given intravenously. So the right option here is the first one. You're suspecting an HSS. Which one of the following finding is suggestive of an HSS they are asking? Glucose values, usually it will be more than 30 millimoles per liter. So this is not. pH should be more than 7.3. Again, it is wrong. Bicarb should be less than 15. Again, it is wrong. Sorry, sorry. A bicarb should be more than 15. So it is right. Bicarb should be more than 15. It is right. Urea doesn't come in the diagnosis at all. Sodium doesn't come in the diagnosis at all. So this is the right option which appeared in the last diet. So bicarbs more than 15, that is 22, suggestive of an HSS goes in favor. Remember the 5 things what we have done. Glucose levels being more than 30 millimoles per liter is one of the criteria. Second criteria, osmolality being more than 320 millimoles per per kg, what we calculate osmolality. Next one is pH being more than 7.3. Next one is the bicarb, which should be more than 15. Fifth one is no significant, that is serum ketone value should be less than 3 plus, less than or equal to 3. less than or equal to 3 millimoles per liter, not 3 plus 3 millimoles per liter. A 54 years old male present to the ED with complaints of a low-grade fever. For past 2 to 3 days, generalized weakness and reduced appetite. He is a known case of asthma. He is on regular medications, including the prednisone is present here. The patient is on cardiac monitor. The vital parameters are given. The blood pressure doesn't respond to the fluids and inotropes. Most likely diagnosis. Steroids, along with blood pressure not responding for both fluids and inotropes. What are we thinking of? Adrenal crisis. Okay, it is an Edison's crisis. Adrenal crisis is also known as Edison's crisis. So the right diagnosis here is the fourth one. So that completes here. Anyone has any doubts, you can ask me. Otherwise, we'll be ending the chapter here. That completes the endocrinology.